inshallah, we'll revise the module of the neuroimaging, and we have some quiz cases as usual. Then we go through these cases, inshallah, and we start by the first case, which is for a male, 23 years old, presenting by fever, seizures, and severe headache. And these are the options.
B. Brain abscess and ventriculitis.
Okay, yes,
Like
and
that.
this is a marginally enhancing lesion in the in the left frontal lobe, which is directly communicating with the ventricle, and this is one of the complications of brain abscesses. It can rupture in the ventricle and also can reach the subdural and the epidural spaces. Then you got pus in the ventricle, and this pus will show diffusion restriction similar to the original abscess. Then the second case,
Colloid cyst.
yes, and this is typical appearance of a colloid cyst, which is considered an intraventricular lesion, and it shows characteristic CT density and no characteristic MRI findings, since it can appear of low signal in the T1 and T2, or can be of bright signal in both sequences, and there are variables depending on the content of the colloid cyst. This colloid cyst is not considered an intraaxial nor an extraaxial lesion. It is an intraventricular lesion. Yes.
Angioma.
Meningioma.
Yes, and this is a densely calcified
Calcified
meningioma
meningioma.
in the CT scan, but it shows contrast enhancement on MRI, and this is known as symptomatous meningioma, where there is little interstitial space, and the meningioma is totally formed of condensed cells, and that's why this meningioma in particular will show intermediate signal in both T1 and T2 weighted images. And you know that the gradient image is more sensitive than T2 for detection of calcium, and you can see that the meningioma is almost totally calcified. However, it is surrounded by some brain edema, and also it shows contrast enhancement and dural base.
There is
My
ischemic change in the left temporal lobe.
Yeah.
venous infarction.
Mid-cerebral artery infarction.
Infarction. Venous infarction. Venous infarction.
Yes. And this is venous
Hemorrhagic
infarction
infarction.
because number one, it is not in the classic territory of the middle cerebral. It is also hemorrhagic, and the MR venography shows that the transverse sinus on the left side, as well as the sigmoid and the internal jugular vein, are almost thrombosed with no signal inside. This signal corresponds to the internal carotid artery, and this is the middle cerebral and the arterial cerebral. There is some overlap of the venous on the arterial sides. Then this patient had a classic history of positional headache, neck pain, neck stiffness, nausea, vomiting, sensitivity to light or sound, and sense of imbalance.
Meningitis.
Leptomeningitis.
No,
Venous thrombosis.
no,
Intracranial hypotension.
yes, this is right. And this is intracranial hypotension. And I don't think that I explained this in my lectures concerning the brain, but they are explained elsewhere in the text. But be careful about diffuse meningeal thickening and enhancement in the presence of this particular history of positional headache. Headache while standing, and is relieved while lying down, together with some other important features. These features I will summarize in the next slide. Then this is a triad of low CSF pressure, orthostatic headache, and a diffuse pachymeningeal enhancement. There is diffuse meningeal enhancement and thickening. Of course, you can consider this as meningitis, as sarcoid, as leptomeningeal carcinomatosa sometimes, but the history is very important for the diagnosis of spontaneous intracranial hypotension. And there are some causes of this hypotension, like the traumatic causes, and also some spontaneous etiology, like meningeal diverticuli, calcified disc herniation, which can perforate the dura. Speculated osteophytes have the same effect, CSF venous fistula, and weakness of the dural sac due to connective tissue disorder. The findings are, as you can see here. Number one is obliteration of the prepontine cistern, flattening of the bones, the anterior aspect of the bones, draping of the optic chiasm over the dorsum celli. And you see that the suprasellar cistern is almost not seen in the image. Then you may got subdural hygromas or hematomas, enlargement or engorgement of the pituitary gland, and ventricular collapse, attenuated ventricles, and engorged dural sinuses. Then if you go to the original case, then you can see that the ventricles are attenuated. There is some subdural collection. There is obliteration of the cistern around the bones, and there is engorgement and enhancement of the sella of the pituitary gland, with acute angle between the internal cerebral veins and the straight sinus. Then we go to another case, and here you can see that there is engorgement of the dural sinuses, a diffuse pachymeningeal thickening, and also one of the important findings in the sagittal images is the downward herniation of the tonsils through the foramen magnum, simulating the Chiari-1 malformation. Then please remember these findings. They are very important for the diagnosis of a spontaneous intracranial hypotension. You got the dropping of the posterior structures, including the splenium of the corpus callosum, acute angle between the internal cerebral veins and the straight sinus, downward displacement of the tonsils through the foramen magnum, obliteration of the prepontine cistern, and the flattening of the anterior aspect of the bones, together with attenuation of the ventricles and the diffuse meningeal thickening and enhancement. You can compare the normal appearance of the corpus callosum by the corpus callosum of the spontaneous intracranial hypotension, and you can easily appreciate the difference. Then the next case.
Adrenoleukodystrophy.
Yes, this is right, and this is a case of adrenoleukodystrophy, where you see abnormalities in the white matter, particularly in the parieto-occipital areas, of low signal in the T1, high signal in the T2, and the flare. And if you inject the contrast, these lesions will peripherally enhanced. And this patient had pulmonary TB, and word finding difficulty, meaning that some deterioration of the memory and so on. And this is an MR spectroscopy, including a contrast enhanced T1 weighted image.
الكولين هاي دكتور.
Yes,
Abscess.
abscess.
بس الكولين مش ظاهر بالابسس.
See, this is the voxel of the normal brain, and this is the NAA, choline, and the creatine, and these arrow points to the lipid which are absent in the normal brain. But in this
هو كده تيومر، هو كلنا عالي والان اي اي قليل، فده تيومر.
Yes, and this is very important. Whenever you are asked about spectroscopy, you look first for the choline. If the choline is high, then you consider a neoplastic pathology. Then forget about the spectroscopy, then go to the MR appearance. If you see enhancement and this is a tumor, what do you think?
ميتاستاتيك.
Yes, metastatic or glioblastoma multiforme. They both can present by the same appearance. Then one of the good policies is to go first for the and look for the choline peak. If the choline peak is not present, think of other diagnosis rather than a neoplastic etiology. I will show to you some of the examples concerning spectroscopy during this session.
This central pontine demyelination.
Yes, and this is central pontine myelinolysis, and you see the Mexican cap, and also you can see some diffusion restriction. And I said in my lectures that these lesions do not show diffusion restriction, and this is good for the chronic lesions, but the acute onset lesions will show diffusion restriction, as you can see here. Then we have to discriminate between acute lesions and the chronic lesions, and we should not usually be confused about the lesion. If it is restricted, someone may think of an infarction, which is not true. Then what do you think about this case?
Oligodendroglioma.
Yes, and this is oligodendroglioma because of the calcium, and you see the tumor, and you cannot see calcium, of course, in the T2 weighted image. Then
Breast.
yes, very good. This is breast, bilateral, almost symmetrical, high signal intensities in the posterior aspect of the parietal lobes on the FLAIR images with no evidence of diffusion restriction. And this is almost typical for the breast lesions. They do not show diffusion restriction.
Dr. why it's not herpes encephalitis?
In the previous case,
Yes.
now the herpes encephalitis, there is number one has a specific location in the temporal lobe, and number two, herpes will show diffusion restriction, not diffusion free. This case, you see the answer, and I would like you to look carefully that these are two different lesions. This lesion is in the medulla oblongata, and this lesion is in the floor of the fourth ventricle. Then two lesions enhancing, and this is a good finding for the diagnosis of metastatic deposits.
Papilloma.
Yes, and the difference between papilloma and carcinoma is the extension of the tumor outside the ventricle. And the extension of the tumor outside the ventricle is known by the development of brain edema at the margin of the tumor. And here you can easily appreciate the presence of some edematous changes along the outer margin of the lesion, diagnostic of choroid plexus carcinoma.
basal ganglia infarction.
Okay.
Hmm.
Bilateral basal ganglia infarction, and this is frequently seen when the internal cerebral veins are thrombosed. But here you do not see any sign of internal vein thrombosis. Then all what we can say here that we have bilateral almost symmetrical basal ganglia lesions, and these are subjected for a big list of differential diagnosis. And this lecture of the differential diagnosis of basal ganglia lesions I will prepare very soon, inshallah, so that you can I can solve this problematic appearance. But in this case, the diagnosis is metabolic acidosis, and there is a characteristic sign here which is known as the lentiform fork sign. And if you look carefully here, you see a very bright signal at the edge of the lentiform nucleus simulating the fork. And the literature says that this lentiform fork sign is one of the diagnostic criteria of metabolic acidosis. And here you can see a classic appearance of the lentiform fork sign associated with abnormalities in the basal ganglia, the lentiform in particular, as well as perifocal edema. This is almost a diagnostic of metabolic acidosis. And this is another example where you can see the classic appearance of the lentiform fork sign. These lesions, according to the underlying cause, where some will show diffusion restriction, as you can see here, and others will not show this diffusion restriction. Metabolic acidosis, as is written here, develops when there is much acid in the body, and this occurs when the kidney cannot remove enough acid from the body. And there are several types of metabolic acidosis, like diabetic ketoacidosis, where accumulation of the ketone bodies which are acidic in the blood, or hyperchloremic acidosis, excess of sodium bicarbonate in patients with severe diarrhea. And in kidney disease like uremia or renal tubular acidosis, you may got these appearance. Then lactic acidosis is one of these, let us say it is the most common form, where there is accumulation of lactic acid in the circulation. And this occurs when the body breaks carbohydrates to use energy when oxygen levels are low. And the underlying causes may be cancer, carbon monoxide poisoning. You remember that one of the best diagnoses for bilateral symmetrical basal ganglia lesions is carbon monoxide poisoning. Then drinking too much alcohol, vigorous exercise, liver failure, hypoglycemia, seizures, severe dehydration, poisoning by aspirin, and medicines like salicylate and metformin, prolonged lack of oxygen from shock, heart failure, and anemia, and the Melas syndrome. Then in order to diagnose this, you require the symptoms and the blood tests, like to look for the blood gases, blood ketone bodies, lactic acid test, urine ketones, and urine pH. And this is a summary for the most common causes for metabolic acidosis, like diarrhea, biliary or pancreatic fistula, renal tubular acidosis, total parenteral nutrition, dilution acidosis, and the recovery from diabetic ketoacidosis, and too many causes. Then you may remember this until I prepare the full lecture and upload it on my website. The next case is a patient.
عفوا دكتور الميتابوليك اسيدوز هذا ريفرسبل ولا ريفرسبل؟
Yes, some of these changes are reversible. What do you think of this case? And I should notify you that this is an artifact.
cyst.
Sorry. What is this image?
T1 axial MRI T1.
No, it's not T1. You see the globe is bright.
That's WI.
Yes, and this is susceptibility weighted image. What do you see here? Is a black line along the
Left
course
MCA.
of the middle cerebral artery, meaning that the artery is thrombosed. You know that susceptibility weighted images are sensitive for calcium and for blood. And this is known as the susceptibility vessel sign. You remember the hyperdense vessel sign by CT? This is known as the susceptibility vessel sign by the susceptibility weighted images. And you got an infarction in the middle cerebral trajectory showing diffusion restriction and the diffusion weighted image, and this is ADC, and this is CT angio showing occlusion of the middle cerebral artery. Then if you see that the one of the vessels is black in the gradient image or in the susceptibility weighted image, and you say that this is susceptibility vessel sign, and you know it is analogous to the hyperdense vessel sign seen in the CT scan. And if you have the MR angiography or any type of angiograms, then you can see occlusion of the artery. Then I should remember you once more. If you are confronted by a spectroscope, then go to the choline beak.
GPM.
This is not the enhancement of GPM. Let us agree about that this is a tumor, okay?
Glioma.
Yes,
Lymphoma.
any type of malignancy. It may be a metastatic deposit, maybe lymphoma, maybe glioblastoma multiforme, and this was a case of lymphoma. But you consider first that the peak of choline is extremely high.
Panda
Sorry?
sign.
Panda sign. What this sign means?
Hepatic encephalopathy.
Very good. And this is Wilson disease due to the hepatic encephalopathy. And the face of Panda is one of the signs that can be seen in the brainstem, in the midbrain in particular, due to the non-affection of the red nuclei and part of the substantia nigra that will appear black on the background of the affection of the rest of the brainstem, of the midbrain. And also you can see the high signal in the T1 and low signal in the T2 and susceptibility weighted image due to the presence of iron in the basal ganglia. And this is the classic appearance of the face of Panda sign seen in the midbrain due to the non-affection of the red nuclei and the substantia nigra, which is joined to the diagnosis of Wilson disease. Next case.
hyperdense vessel في CT.
Laminar cortical necrosis.
No CT here. This is MRI T1 and this is diffusion.
Laminar cortical necrosis.
No, laminar cortical necrosis means that the cortex which is 2 or 3 millimeter thick on the surface of the brain, is transformed into a bright signal ribbon underneath the calvarial bone. But this is only a linear structure that is bright in the T1 weighted image with restricted diffusion. What do you think?
Thrombosed
Yes, and this
vein.
is one of the superficial veins that is
Rollard.
thrombosed. And whenever the vein or the artery is thrombosed, you got linear high signal depending on the stage of the blood. And this may be a subacute blood because it is bright in the T1 weighted image. And you know that blood may produce diffusion restriction, and that's why we do not usually need the diffusion weighted images if we know beforehand that the patient had hemorrhage. And
Subcortical arteriosclerosis.
no, do you read the history? Actually, some of your colleagues asked me to talk a little bit about the MS. Then you know that MS, I will show the text of MS in a moment. MS can affect the patients in the usual age, which is between 20 and 40 years of age. And it may go with the patient up to the age of 50 or 60. Then how can you separate these lesions that definitely they are MS from the subcortical arteriosclerotic encephalopathy based on the patient age? Actually, it's only the history and the previous films which can tell you that you are dealing with a case of MS or a case of ischemic encephalopathy. Then let's go to the MS. MS is an autoimmune disorder. It has a characteristic course with relapsing and remitting pattern. But some of the patients may undergo a chronic progressive course. This course may persist with the patient in the 50s and 60s. MS is common in women, usually presents in young adults, but it can go with the patient in old age. Then these are some of the syndromes that can help you to spot the diagnosis of MS beside the characteristic appearances on MRI. Number one, the presence of optic neuritis. And this is usually acute unilateral loss of vision with eye pain, which is worse by movement. Number two is internuclear ophthalmoplegia with characteristic horizontal eye movement. Then ATOF phenomena. ATOF phenomena is a worsening of neurological symptoms with increased body temperature. If you have a hot bath, then you may got this worsening of neurological symptoms. Lermet phenomena means a transient electric sensation in the spine and limbs when the neck is flexed. And please consider that this sign can occur in other lesions compressing the cord. Then this image summarizes the manifestations of the MS throughout the whole body, the CNS, the throat, the sensations, the urinary system, the bowel, musculoskeletal, the speech, and the vision. Then one of the Diagnostic criteria of MS separating it from encephalopathy is enhancement of the lesions. Lacunar infarctions do not enhance, but active MS plaques usually show enhancement in the post-contrast series. Then these are the criteria helping you to spot the MS. Number 1, the age of the patient. Number 2, the clinical course. Number 3, optic nerve involvement. Number 4, periventricular lesions, and I will explain this. Then periventricular lesions perpendicular to the corpus callosum, which is known as Dawson's finger. Then contrast enhancement of the active lesions. These findings are not considered periventricular. Lesions that do not touch the lateral ventricle, like these lesions. Anterior and posterior symmetric periventricular capping. These are not considered in the lesion. Lesions smaller than 3 mm in long axis and the symmetric high signal intensity abutting the lateral ventricle. These are not considered periventricular lesions. Then we came to another case. This is T2, post-contrast and diffusion.
Lymphoma.
Yes, and this is a spot case of lymphoma because of diffusion restriction and inhomogeneous enhancement. And this is a male child, 7 months old, with macrocephaly. What do you think?
Leukodystrophy, metachromatic.
Alexander.
These are the
Cerebral
suggested
atrophy.
diagnoses.
Cerebral atrophy.
Cerebral atrophy.
هو
ألكسندر.
لحد سنتين ما تقدر تقول
Alexander
اتروفي.
is not present here.
Metachromatic.
Metachromatic is not present in the suggested options.
Acquired state of obstruction.
Canavan.
And this is a benign enlargement of the subarachnoid CSF space in infancy. And the clue for the diagnosis is this. You cannot diagnose this benign enlargement of the subarachnoid space without knowing that the patient had microcephaly. It is unlogic to diagnose cerebral atrophy in patients with macrocephaly. In patients with macrocephaly, they are looking for hydrocephalus. But in absence of hydrocephalus, and you can see that the frontal and parietal subarachnoid CSF spaces are wide, but the ventricles are normal, and this is known as benign enlargement of the subarachnoid CSF space in infancy, and this resolves spontaneously at the age of 2 years. Then please remember that if you have a child with macrocephaly and you see this appearance, this is not atrophy. And this is the usual appearance of the white matter in this age group. Then this is what we call benign enlargement of the CSF spaces in infancy. Macrocephaly is essential for the diagnosis. What do you think?
Kaisencephaly.
No,
Kaisencephaly.
no, no.
The same case تقريبا ولا؟
No,
glutaric aciduria.
yes, and this is glutaric aciduria type 1. And I hope that you have go through with the third part of white matter diseases. It was not included in the previous diplomas, but I prepared this final part of white matter diseases and I put it in the curriculum. Then glutaric aciduria means that it's very characteristic that there is some, let us say, atrophic changes or cystic appearances of the sylvian fissure, bilateral and symmetric, together with the classic appearance of delayed mental growth, speech disturbance, and abnormal size of the head. And this is one of the cases also you can diagnose by the presence of macrocephaly. This is an autosomal recessive disease and it affects the mitochondrial activity, leading to accumulation of glutaric acid in the brain and the body fluids, including urine, and that's why the name of the disease. This is an autosomal recessive, as I have mentioned, so consanguineous marriage are at high risk of developing this disease. Macrocephaly is one of the prominent features in this particular disease, and the patient may develop acute encephalopathy after infection or acute attack of GI disturbance. The initial presentation may be similar to viral encephalitis or ADEM. Then if you look to the brain CTs or MRI, you see the characteristic appearance of the bat's wing configuration of the sylvian fissures. Then these bat's wing or enlargement of the sylvian fissures may be due to atrophy or may represent arachnoid cysts. This is an important statement. Macrocephaly with extrapyramidal symptoms are almost pathognomonic of glutaric aciduria type 1. And this is the clinical presentation: macrocephaly, extrapyramidal symptoms, and the initial presentation may simulate viral encephalitis. Next case is a 50 years old male with headache and scalp swelling.
Atypical meningioma.
Okay.
Hemipericytoma.
Sorry. Atypical meningioma is a good possibility. What other?
Hemangiopericytoma.
Hemangiopericytoma. Another?
Extraaxial lesion, this one is.
Yes, it is. You remember that I have told you usually in the head and neck in general, if you are confronted by a lesion, the differential diagnosis is almost easy. You mentioned the primary lesion that can show this appearance. Then you mentioned after that lymphoma and metastasis. This is the sequence of events. Then you have said that this is a typical meningioma, good, and meningiopericytoma, good. Then if you are asked what else, you say lymphoma and metastasis. And this term is an old one, which indicates a malignant meningioma. It's no more used, but the term atypical meningioma or meningioma grade 2 or grade 3 is usually the preferred term nowadays. It is enough for you to say that this is a typical meningioma, or even to say hemangiopericytoma is good. But whenever you are asked about the differential diagnosis, you should say lymphoma and metastasis.
Medulloblastoma.
Yes, and this is a straightforward case of medulloblastoma because of the diffusion restriction. This is the only posterior fossa lesion that can show diffusion restriction up till now. This patient had history of trauma, and these are the possibilities.
developmental venous anomaly.
Developmental venous anomaly.
Subarachnoid hemorrhage.
Yes, and this is subarachnoid hemorrhage. And the CT scan, you see high density in the sylvian fissure with edema. In the susceptibility weighted image, you see the signal of blood in the sylvian fissure compared to the opposite one. And this is diagnostic of the subarachnoid hemorrhage.
Ischemic.
Yes, what kind of ischemia?
Hemorrhagic infarction.
Non-hemorrhagic.
Yes, and this is hemorrhagic infarction because of the presence of low signal foci in the susceptibility weighted image, and you can see diffusion restriction in the diffusion weighted image.
Giant cavernoma.
Yes, and this is right. This is a giant cavernoma diagnosed by the presence of blood elements seen in the susceptibility weighted image and also in the T1 weighted image with the characteristic hemosiderin rim and the minimal perifocal brain edema.
Multiple cavernoma.
No. They are not.
Chronic
Diffuse axonal injury.
No. And for diffuse axonal injury, you should have a definite history of major trauma. If you don't have this, look for another diagnosis. But you know, in the recent lectures, that the patients with hypertensive encephalopathy may develop microbleeds, and that's why the gradient images or the susceptibility weighted images are essential in the protocol of examination of such cases, because if you detect microbleeds, then you should mention this very clear in the report to guard against the anticoagulant if the clinician is about to give the patient any form of anticoagulants. And this is known as hypertensive microbleeds or chronic hypertensive bleeds.
glioblastoma.
Yes, and this is glioblastoma, typical appearance with marginal enhancement, central necrosis, some blood signal inside the tumor, all the features of glioblastoma multiforme.
Also glioblastoma.
No, that's
Infiltrating glioma.
this is
Infiltrating
not
glioma.
heterogeneous enhancement. This is homogeneous enhancement. And the T1 weighted image, you do not see evidence of blood. But in the T2 weighted image, you see some darkness in the tumor, which are suggestive of calcium. And if you look carefully, and you see a good dural base for the tumor in the against the meninges. And this is a meningioma, which is a typical form of meningioma. Okay. BXA is a good diagnosis because of the cystic lesion with an enhancing mural nodule, and nodule is peripherally located.
Abscess.
Okay, and the abscess usually show diffusion restriction. Is it true?
Yes.
But
Abscess
here
diffusion.
it is not totally diffusion restriction. It's only part of the lesion that shows diffusion restriction, and the remaining part of the lesion shows diffusion free. And this is an important finding in the
Treated
fungal
lymphoma.
abscesses. The fungal abscesses do not show diffusion restriction, but the biogenic abscesses show diffusion restriction. Of course, from the MR spectroscopy, you do not see any of the metabolites. You can see only the lactate and some amino acids and so on. Then you know that this is an inflammatory lesion, and because of the marginal enhancement, you say that this is an abscess. And if you go to the diffusion restriction and you do not see diffusion restriction, then you think of a fungal abscesses.
Sturge-Weber.
Sturge-Weber, yes. This is a straightforward case of Sturge-Weber syndrome showing all the criteria: hemiatrophic changes, leptomeningeal enhancement, and the enlargement of the ipsilateral choroid plexus in the ventricle. And this is the classic appearance of Sturge-Weber.
Subependymoma.
Very good. And this is subependymoma because of the absence of enhancement. It's an intraventricular lesion that is exactly similar to the ependymoma, except that in about 60% of the tumors, they do not show enhancement.
Hemorrhage.
Yes, and this is the patient had myocardial infarction, diabetes, and hypertension. Then you know that cerebellar hemorrhage is the second following the temporoparietal or the middle cerebral territory hemorrhage in the sequence. Then first, this is the most common site for hemorrhage, and this is the second most common site for hypertensive bleeding.
Dermoitis.
Yes, and you should say
Fat seeding.
yes, with leakage in the subarachnoid space and maybe inside the ventricles as well. The lesion showed fat density in the CT with marginal calcification, and it shows high signal in the T1, denoting the presence of fat. And you can see also fat globules scattered throughout the subarachnoid space. I think this is the only lesion that can affect the globus pallidus. Bilateral and symmetric.
Hypoglycemia.
No, this is methylmelanotic acidemia. Methylmelanotic acidemia. And this is also in the third part of the white matter diseases. Methylmelanotic acidemia is an autosomal recessive disorder, and the body is unable to process certain proteins and fat, leading the accumulation of harmful amount of organic acids and toxins in the body. And this will cause amino acidopathy that will affect the mitochondrial activity. And the presentation on imaging is a classic bilateral symmetrical abnormal signal in the globus pallidus. These are the suspected or the possible symptoms: decreased consciousness level, difficult in breathing, vomiting, muscle weakness, low energy or lethargy, and low body weight. And this is the almost the typical appearance, where you got abnormal bilateral symmetrical high signal in the globus pallidus of the lentiform nucleus.
Epidermoid cyst.
Yes, Yes, intraventricular epidermoid cyst in the fourth ventricle. The cyst has lobulated outline. It did not show any contrast enhancement, and it shows evident diffusion restriction.
موية
Moya. This is contrast enhancement.
meningitis.
Yes.
meningitis
Meningitis, basal meningitis with enhancement of the basal meninges. Maybe tuberculosis, maybe other etiology, but meningitis is the right answer.
Cavernoma.
Yes, multiple cavernomas or familial cavernomatosis. And you see the classic appearance of the lesions that appear somewhat hyperdense in the pre-contrast. If you inject contrast, they will not show significant enhancement, and there is no perifocal brain edema with little, if any, mass effect.
empyema subdural
Yes,
empyema
subdural empyema, the classic appearance with marginal enhancement in the interhemispheric fissure and the diffusion restriction in the diffusion weighted image.
also meningitis.
Yes, and this is another case of meningitis. And most of the cases of meningitis, if you do not know actually the cause, you may call that this is secondary to TB.
hemorrhage
Yes. Hemorrhage.
Subarachnoid.
intracerebral hemorrhage and
Okay, this is
intraventricular.
a contrast enhanced image, and this is a
موية
yes.
موية
Yes, and this is
and
Moya disease. You do not see the main stem arteries in the anterior cerebral or middle cerebral, and you know that Moya disease may present by hemorrhages or by infarctions or both.
Aneurysm.
No,
basilar tape
basilar artery obstruction.
basilar artery
thrombosis.
thrombosis. Yes, and this is basilar artery thrombosis. It can be associated with abnormalities in the brain stem or not, but be careful before diagnosis this basilar artery thrombosis that you should go through the images to confirm the existence of this, because many times you may be confused by atheromatous calcifications in the basilar artery in old age, and you misdiagnose this as basilar artery thrombosis. Of course, the basilar artery thrombosis will present by major symptoms, and this is very important.
encephalomalacia.
No.
Arachnoid cyst.
Arachnoid cyst.
Arachnoid cyst.
Yes, this is an extraaxial diffusion-free cystic lesion of CSF containing. If this is encephalomalacia, you can see that there is a vacuodilatation of the adjacent ventricle, but this is not the case. This is arachnoid cyst in the Sylvian fissure.
Papilloma.
Yes, and this is the classic appearance of choroid plexus papilloma. Absolutely intraventricular with strawberry margin and this significant contrast enhancement. Yes, what do you think? This is a T1 weighted image, showed mixed signal intensities, hyper and
autonomous.
And in the T2 weighted image, there is a predominant low signal, and in the contrast enhanced image, there is a strong, intense contrast enhancement.
Lymphoma.
No, this is the history, sudden onset. This is acute lesion. Okay, this is once more a fungus infection of the brain. And how can you know that this is fungus? By the extensive enhancement of the lesion after injection of contrast. This is almost a classic appearance. And whenever I am consulted about such cases, I say with great confidence that this is fungus based on the intense enhancement, number one, and the low signals of the lesion in the T2 weighted image, number two. Then if you consider the acute onset, you know that this is an inflammatory lesion in the brain. Then please remember the intense enhancement of the fungus and the post-contrast, and the absence of diffusion restriction in fungal abscesses.
infarction,
Yes,
thrombosis.
hyperdense
yes, hyperdense vessel sign and
vessel sign.
the infarcted area in the right side with diffusion restriction, simple appearance of a hyperacute or acute infarction.
This is
Arachnoid cyst.
No,
no, not
Cavum septum
كيفم
Yes, yes, yes.
فيلم انتربوزيتم.
yes,
interpositum.
true. This is cavum septum interpositum or cavum velum interpositi, and the most characteristic appearance is the triangular shape of the lesion, and characteristically located in the midline in the posterior aspect of the quadrigeminal system. Most of the cystic lesions occurring in this area do not have the triangular appearance, and this which separates the cavum velum interpositum from other lesions, since the cavum septum interpositum do not usually need any intervention unless it is large enough to cause obstruction of the aqueduct in some cases. In the sagittal image, you can see this oblong appearance, but the appearance in the axial image is quite diagnostic.
Cysticercosis.
Yes, and this is neurocysticercosis with the classic cyst and dot sign. And you remember that I have mentioned if you see this appearance, you should diagnose cysticercosis. And you can see if you have too many lesions and one only fulfill this criteria, you diagnose neurocysticercosis.
Arachnoid cyst.
Yes, and this is a cerebellobasicine angled arachnoid cyst based on the smooth margin of the lesion, the CSF signal, and the diffusion free of the lesion. This you know that arachnoid cyst is usually located against the greater wing of the sphenoid, but it can occur also in the posterior fossa with maintaining its classic imaging criteria, including the smooth margin, the CSF density, and signal intensity. There is no enhancement and no calcification and no diffusion restriction. This is the lesion which is now seen frequently in the clinical practice, known as limbic encephalitis. And this limbic encephalitis looks like the mesial temporal sclerosis, except it is bilateral and symmetric and produce diffusion restriction. You remember that if you have affection of the hippocampus and the amygdala on one side, which will appear of bright signal in the FLAIR images, then you say that this is mesial temporal sclerosis. But if you see bilateral lesions affecting the whole course of the hippocampal system, the amygdala, the hippocampus, the body, and the tail of the hippocampus, then you know that this is known as limbic encephalitis. What is limbic encephalitis? Limbic encephalitis is an inflammation in the limbic system. What is the limbic system? It is the hippocampus and the amygdala, and also the limbic encephalitis is not a pathologic diagnosis, it's an anatomical diagnosis, meaning that limbic encephalitis is an imaging finding for another disease. And in all cases, they do not have the same cause, and in many cases, you cannot know the exact underlying cause. And this video, I'm not sure that you can see it through the Zoom facility.
Welcome to 2 Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the limbic system.
It will be recorded.
The word limbic comes from the Latin limbus, which means border, and the limbic system was given this name because its structures lie along a horseshoe-shaped area of cortex that appears to be a border between the cerebral cortex and the subcortical structures of the encephalon. There are many processes associated with the limbic system, but the system is most frequently linked to emotion. There is no consensus on the structures that are considered a part of the limbic system, and some argue that it is too much of a simplification to consider something as complex as emotion to be handled by one group of brain structures. Regardless, these are some structures that are often included in the limbic system. The amygdala is an almond-shaped collection of nuclei found in the temporal lobe that seems to be especially involved with fearful and anxious emotions. The hippocampus is next to and interconnected with the amygdala. Although it is considered part of the limbic system, the hippocampus is generally associated with memory more so than emotion. The parahippocampal gyrus is an area of cortex that surrounds the hippocampus and also plays a role in memory. The cingulate cortex or cingulate gyrus is found just above the corpus callosum and is involved in various aspects of emotion and memory. The septal nuclei have connections with a number of other limbic structures and are thought to be especially important to pleasure, reward, and reinforcement. The mammillary bodies are two groups of nuclei that are involved in memory and have extensive connections with the amygdala and hippocampus. The fornix is a fiber bundle that carries information from the hippocampus to the mammillary bodies and then on to the thalamus. The hypothalamus controls hormone release via the anterior pituitary and can exert widespread influence over bodily states to maintain homeostasis. While there are other structures that may be included in the limbic system, the structures identified here are some that are commonly considered part of it.
Okay. And actually, this video is extremely informative, and I could not appreciate the anatomy of the limbic system before I can see this video. So it will be recorded on the lecture, and you can have it from the website. The second case, or the next case, is a CT and MRI.
AVM?
Sorry?
AVM?
No?
multiple cavernous.
No?
calcification.
oligodendroglioma,
No?
No.
And here you can see
calcified vein.
calcified. Okay, you see multiple dots of calcifications. Some of them are in the extraaxial space in the suprasellar cistern, and others are located in the brain, and they are surrounded by some edematous changes, and these are calcified tuberculomas.
Yes.
Okay.
Hematoma.
Subdural hematoma.
Subdural hematoma.
Right or left?
Left.
The remaining brain is normal.
No, there is a ventriculomegaly.
Yeah.
hydrocephalus.
Yes, and this is actually this will be discussed in great details in the pediatric section. This is a hypoxic ischemic encephalopathy of an infant with a subdural hematoma. Okay.
Atypical meningioma.
Yes, and or
lymphoma or
or
metastasis.
yes,
Hemangiopericytoma.
yes, atypical meningioma, hemangiopericytoma, lymphoma, and metastasis. And you can say that in the same sequence. Okay.
Encephalitis.
Yes, and this is herpes encephalitis.
Herpes
It is
encephalitis.
bilateral, non-symmetrical temporal lesion affection and the diffusion restriction, classic appearance of herpes.
Hydatid cyst.
Yes, and this is intraventricular hydatid cyst, classic appearance with daughter cysts inside the major one.
GPM.
Okay, and this was the first diagnostic possibility, and they asked for MR spectroscopy.
Abscess.
In a MR spectroscopy, you do not see elevation of the choline nor the N-acetyl aspartate, but there is marked elevation of the lipids and the lactates.
Of the abscess.
Yes, and this is actually was proved to be a giant tuberculoma. You know that the biogenic abscess do not contain such an intracavitary lesion, but the tuberculoma may contain this lesion due to caseous material and associated pus component.
X-ray.
No, this is not cystic. This is solid, homogeneously enhanced lesion.
Atypical meningioma.
Classic meningioma. You do not see N-acetyl aspartate because this is not a neuroglial tumor. And you can see the alanine peak, which is inverted because this is a long TE sequence. And you have elevation of the choline, which is an indication that this is a tumor.
Meningitis.
No, please read the history. It's very important.
Molecular hypertension.
Yes, and I have mentioned before that the history is very informative. Postural hypertension, a headache is one of the best diagnostic clues, including the previous surgeries in the lumbar spine or any cause for CSF leak. Then you got the appearances of diffuse enhancement of the meninges, which is related to intracranial hypotension.
Plaque meninges due to metastasis.
Okay, this is meningeal metastasis, and where are the metastatic deposits? This is one, and the diffuse meningeal enhancement in the presence of a known malignancy, you consider that meningeal carcinomatosa.
pilocytic astrocytoma.
Okay, actually, you are right, almost right, but this is a new tumor which is known as pielomyxoid astrocytoma. It is almost similar to the pilocytic astrocytoma, but is now recognized by WHO to be a grade 2 glial tumor. Actually, you cannot reach by any means this diagnosis, which is pielomyxoid astrocytoma. Then why I presented this case? In order to let you know that there is a new tumor which is known as pielomyxoid astrocytoma. Then whenever you heard about this tumor by histopathology, by any ways of surgical procedures, then you know that this is a WHO grade 2 tumor, which is common in the pediatric population. It has exactly similar appearances to the pilocytic astrocytoma with a cystic component and an enhancing mural nodule. And the tumor can bleed. The tumor can show contrast fluid level similar to the pilocytic astrocytoma. And on MR spectroscopy, it is also similar to the astrocytoma with elevation of the choline peak and depression of the N-acetyl aspartate.
Central neurocytoma.
No,
craniopharyngeal.
no.
No, for both.
Then what is the diagnosis?
I don't know.
And this is epidermoid cyst actually. You see that the cyst is of low signal in the T1, and in the FLAIR it is not of CSF signal, and in the EDC it shows diffusion restriction, and this is epidermoid cyst. This patient had sudden onset of hemiparesis and disturbed conscience, and was diagnosed recently with locally advanced squamous cell carcinoma of the piriform sinus. Then this is MRI of the brain T1, T2, and with contrast, and this is the MR spectroscopy.
Metastasis.
No, no choline at all. You see this?
Lymphoma.
Radiation
You
necrosis.
see this? What is this?
Yes.
Succinate.
Succinate, which is present in abscesses. Succinate and amino acids are seen in abscesses. Then it is not strange that the patient with a primary malignancy to develop a brain abscess. And here you can see that there is no metabolites in the NAA, creatine, or the choline. Instead, you have amino acids, you have lactate, and you have succinate. Then you know that you are dealing with an inflammatory lesion, which is marginally enhancing diagnostic of the brain abscess. هذا وبالله التوفيق.